So, what I'd like to talk about today is the artificial intelligence uh, connection to radiation oncology. Just for a show of hands, how many radiation oncologists do we have in the audience? So, okay, so not so many. So so I will try to clarify some of the things that I'm going to say. So, if you go back in the literature, what you can find is the first kind of mention of adaptive radiation therapy and what it means all the way back to 1997. And this is by Alvaro Martinez's group and a physicist, Icahn. And I just like to read it because I think it really summarizes everything I'm going to say in the next 20 minutes. Adaptive radiation therapy is a closed loop radiation treatment process where the treatment plan can be modified using a systemic feedback of measurements. Adaptive radiation therapy intends to improve radiation treatment by systematically monitoring treatment variations and incorporating them to re-optimize the treatment plan early on during the course of treatment. And in this process, the field margin and treatment dose can be routinely customized to each individual patient to achieve a safe dose escalation. So this is way back when a lot of the things that I will discuss didn't even exist. But it's the whole concept uh, about changing the radiation plan at some point during the treatment, either during the treatment or at some point marking points during the treatment. And I'll discuss that as I go forward. So this slide just discusses the types of adaptive radiation therapy. So since we have a lot of non-radiation oncologists, quick summary of how we work. Essentially, we take a patient and we do, for most people, a simulation, which is we immobilize the patient, and then we take, in most cases, a CAT scan, usually at 5 millimeter cuts throughout the area of interest. We then go back and we manually contour the area of interest. We have different names for it. So we can call the GTV, the actual tumor, the target that we're interested in, gross tumor volume. We have CTV, which is the clinical tumor volume. So that could be an organ that the tumor is in that we want to treat. That could be called the clinical tumor volume. And then there's the planning treatment volume, the PTV, which is basically giving a margin to the CTV or the GTV that we want to treat. So when I discuss with patients, maybe the main differences in prostate cancer between a prostatectomy, which essentially removes what we would call the GTV, prostate, with very little or no margin, we can add as much margin to create what's called the PTV as we want to. We're only limited by the normal structures and their tolerance. So what we do is we will take a CT scan. We will outline all these structures, normal, prostate, bladder, in this case, for prostate cancer, rectum, small bowel, anything that we want to put in there. We then hand this information, the CT scan can be then looked at in 3 dimensions. We give it to our physicists, and they will design how the linear accelerator will deliver that radiation, and it produces a radiation plan, which is 3-dimensional isodose lines, which we can scroll through and look, as well as what's called dose volume histograms, which tell us the amount of dose given to different percentages of the target, as well as the normal tissue. So that's the basic thing that we do. And then we put the patient on the machine, and traditionally, nowadays, and in the past, we use X-ray imaging to determine whether we were in the right position, or now we use cone beam CAT scans, which are built-in CAT scan units on the machine. This is a traditional way of doing it to see if our target is matching up to our planned target. And we have a plan, and that's what we do. And we're either doing that sometimes live for SBRT. We're actually looking at a cone beam scan, seeing if the prostate is moved, if the normal tissues are in the same position, or sometimes we're taking scans for more conventional fractionation, and maybe the therapists are checking it, and we're checking it at the end of the day. So that's standard treatment that we do. So what is adaptive radiotherapy? So there are really 3 categories. There's offline adaptive radiotherapy, which can take hours to days. The adaptation is slow changes. You're using these scans infrequently, 1 time, 2 times, 3 times per course. It's less resource intensive. You can take these images that you get when the patient's on treatment, bring it back and analyze it. You can do a combination of manual and automative contouring. So there are now programs that can do contouring of normal structures, but continually, most of the stuff is still done by hand by the physician, and you can use various diagnostic imaging. So that's offline RT. You can then take that information, make some changes, and you could actually change your plan, as I mentioned earlier, and come up with a new plan at some point, and then implement that new plan on the patient. So that's offline adaptive radiotherapy. Online adaptive radiotherapy is something that can take minutes, can be done. It can adapt to actually daily changes in either the tumor or normal structures. It's certainly more frequent. As I said, it can be based on imaging, and you can make changes actually on a day-to-day basis. It's certainly very resource intensive because, one, you need a machine that's capable of doing it. You need physicists, as well as right now, physicians or some form of artificial intelligence to recontour all the structures every time you're doing it and continually generate new plans. Certainly, it will require higher degrees of automation, and it uses, as I said, these onboard imaging of some kind, either MR or CT, essentially, is what we're using now, although you can use additional imaging. And then real-time adaptive radiotherapy can take seconds. It can adapt to motion and interfraction motions within the treatment, and it requires, again, some kind of real-time imaging while the patient's being treated. So this is just a schematic of a review article in Seminars in Radiation Oncology, practical clinical workflows of online and offline adaptive radiation therapy. And again, just kind of summarize graphically what we do. So it's basically conventional planning. As I said, we're taking images, we're generating a plan. And for those that aren't radiation oncologists, using what's very common now, intensity modulated radiation therapy, IMRT, is that the machine is designed to move around the patient or have different angles with leaves that can come in and out of the field and modulate the radiation. But in order to verify that we are doing the correct dose before a patient is actually treated, we do a QA process where we have a phantom and we run the plan and make sure that the dose distribution is indeed what we're seeing, just as a QA validation. For offline RT, again, you have that information going on, and then as where it's set, as if you look at the graph, that you're treating the patient, and then at certain points you're capturing some of these CT scans and either averaging, summarizing them using AI. You're making something of it to basically look at what you're capturing. Are the organs in the same place? Is the tumor in the same place? Has it moved? What's going on? And then you make changes that way. Well, I said online, again, it's the same process, but it's actually happening real time. So you're taking a scan. It could be a CT, it could be an MR. You're making an assessment of the volume, and then you're making a new plan and you're changing it. So that's what we would consider online adaptive radiation therapy. So you can see right off the top, the online is the real challenge. That's the one that certainly today, and I'll talk about what is in use today, is extremely time consuming because you're continuously replanning based on what you're seeing. And the question, I'll bring it up now as we go through the slides, the real question is prostate the best site to really be testing this? And is it something that we really need in prostate cancer treatment? So here's just another offline adaptive radiation therapy workflow. Again, a lot of this work that I'm showing you, why it's a little difficult to get this to kind of to an audience that are not radiation physicists, is radiation physics. This is almost all radiation physics that we're talking about. So it requires to kind of get this to a lay audience, so to speak. It's a little bit difficult to pick out the information from the literature. But mostly these workflows follow standard planning processes. There's triggers for when to adapt the plan. There's resimulation or replanning. And then, of course, again, this QA to make sure that when you have a new plan, that is indeed what's actually going to be delivered. And so, again, you're depending on when you're going to image, how often you're going to image, how often you're going to replan. A lot of things go into play here. So these are the most common units now being used, although I think that adaptive radiation therapy will be probably implemented with standard linear accelerators. But for now, the two main units are are made by companies, and they're basically tomotherapy units. And what that means is that it's like a CT scan. It has CT scan capabilities, and it's a linear accelerator that's rotating around just like a CAT scan. There are two major companies now. One of them is an older version of what's called the Tomo unit, now being made by Accuray, and another one is a separate company. But again, the process is that you can get quick images and hopefully quick physics changes, and then implementation with treatment. So these are the two main companies. And then the third thing that's gained a lot of interest is MR-Linac, which the hallmark of MR-Linac, or why we using MR-Linac, why we're implementing. And just to know where I stand in this, so Mount Sinai, we are actually getting one over the next year to 2 years. The plan right now, and then I'll touch, is not really to use prostate as the main target for this, but we are. But I'll go over what some of the unique tumor sites are. But this is just an example of an MR-Linac that, again, is going to be able to use MR imaging to make the changes for the adaptation. So this is just a slide that came out, now it's almost 10 years ago, evaluation of offline, online images and adaptive approaches for prostate cancer therapy. And the reason I just put these slides up, and I would like you to kind of compare the first column to the second. And for those of you who are radiation oncologists and check this stuff real time, especially for SBRT, you know what I'm talking about. And so on the left, you'll have a plan, and the green is the target. You know, you might call it the GTV. In the first slice, it's seminal vesicles. And you can see on the day of treatment, you have a plan. It exists in relationship to the patient and pretty much to their bony anatomy. And then you go ahead and do a CAT scan, and you come to check it, and you see that the target that you're looking at, whether it be the seminal vesicles or prostate, may not necessarily be in the same position. And so you can see, comparing the column, the first column to the second, that now the seminal vesicles, which were completely covered on the first cut, now seem to be coming out of the isodose line that you want. So there's an issue. Now let's look at the second row, a prostate. So you can see this is a bigger change, where the prostate neatly fit into that red line, which is the dose that you want. And now when you take the patient and you look at it and you superimpose that dose, you can see that now it's outside of that. So that there is a problem here. Now, how does that happen in prostate? Is the prostate actually changing? I would say no, but we have two other things that are influencing where the prostate is. One is bladder fullness, and the other is rectal fullness. And then if you kind of go down the columns, you can see again seminal vesicles in and out of the field based on just normal changes, and you can see that in the last row as well. So is prostate the best thing? Should we be replanning all these things based on this change? And I maintain, because I do a lot of this and do a lot of SBRT and a lot of real-time cone beam checking before treatment, is that if you follow a strict protocol in terms of bladder filling with a full bladder, and that means giving the patient at the time of simulation and at the time of treatment the exact same number of cups of water, and waiting the exact amount of time for that water to basically pass through, get digested, filter through the kidneys and into the bladder, you can pretty much get the same bladder filling. It's not perfect every time. And the same thing, let's say for SBRT, where it's 5 high-dose treatments. I'll talk about that later in the course. We make our patients have an enema, so that we are clearing out the rectum so that it is in the same state at the time of simulation and at the time of treatment. If you do these things, you will see less changes. If you have markers in the prostate, if it's radioactive seeds that you're combining with it, or the fiducial markers, it is very easy to match up and see the changes. Now, you can then make changes. You can move that whole field up and down by millimeters and get very, 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 very close to perfection. Is it perfection? No. Can adaptive therapy make a difference? Perhaps. But I maintain right now, at least at my comfort level, that what we're doing, what most of us do, especially if we're there looking at this and we have good therapists, I'm not so sure how much gain we're going to get with adaptive therapy in prostate cancer. That's my personal opinion. But there are, as we're going to go see, other areas where I think it can make a difference. So this was just an interesting study that I took out from the Netherlands, and the purpose of the study was to determine the planning, again, this planning target volume (PTV) for adaptive radiotherapy procedures, and they use basically this is again what we consider offline imaging, not online. 5 CT scans taken during the course of the treatment on 19 patients, and what they initially did was that they basically had this PTV again, which is the target, in the case the prostate, and a margin around it, and that is your PTV in this case. And they went from having a 1 centimeter margin. And then by taking these scans and basically averaging it out and looking at the dose that everything is getting and the position of the prostate, they made the conclusion was that using an adaptive offline procedure allows for reduction of the PTV margin to 7 millimeters without decreasing the coverage of the prostate. So what happens when you reduce the margin? Less normal tissue irradiation. This is just a more recent article, Machine Learning Automated Treatment Planning for Online MR Guided Adaptive Radiotherapy. And basically, it's all about, again, looking at the accumulation of normal tissue doses and dose to the tumor and making adjustments. And what you can see on the graphs on the bottom is by making these adjustments, and what you see thrown around, if you read this deformation, so deformation of volumes, deformation of dose, changing the shape of dose as you go on, and the shapes changes that you can reduce, in this particular study, bladder and rectal, while keeping the clinical target volume at the same dose. This is, again, another online adaptive radiotherapy potentially reduces toxicity, and this is a subset of high-risk prostate cancer patients. So again, you start out with a rigid scanning, and then you have translation into dose distributions around the tumor, and then you can deform the dose shape based on the current imaging, in this case using MR and CT. And then you can also then calculate the cumulative dose to the normal tissues over time. So imaging is very important for adaptive radiation therapy. Because of the extended timeline, offline adaptive radiation therapy can afford you can use multimodal imaging for planning. You can CT, MR, and PET and bring it all in if you need to change the plan. And again, it will give you the information for the anatomic. You can use biologic if you're using PET scans and integrating that, and functional imaging. So this is just showing some MR images, looking at MR. What's good about MR? It's great soft tissue contrast. It's non-ionizing radiation. So if you're doing cone beam CT scans like we do now, the patient is getting ionizing radiation every day, or if you're using that on a daily basis. And you can also use multiple MR sequences, which may provide different information and may be useful. PET imaging, what's good about PET imaging? Well, it can look at the response of the cancer and adapt during the response. Now, is this the best thing for prostate cancer? I'm not sure, but certainly this is looking at some head and neck cancer. If you look at A, you can see a tumor. The yellow is the PET imaging showing the tumor. And you can see that that begins to change as you go through the therapy. And if you're using adaptive therapy, you can actually change the shape to reduce. Again, the whole goal is for radiation oncologists, target the area that you want with highly conformal radiation and minimize dose to the normal tissue. So if your tumor is shrinking, let's say you had a lymphoma or some other tumor that's actually shrinking, you might be able to, with adaptive therapy, change the shape of that. And as you do that and reduce the volume, as I mentioned in that earlier study for prostate, you reduce dose to the normal structures. If you look at the second row, again, you can see another head and neck tumor, bright yellow. Maybe after the first week or 2 weeks, it could be disappearing. Are you going to continue to treat that same volume? Maybe, or maybe you're going to get smaller and reduce normal tissue. So just to kind of a couple of summary slides, triggers for offline adaptation, anatomical triggers, tumor shrinkage or tumor growth, changes in the patient's weight, and then a dosimetric increase in the organ at risk dose might make you want to change or decrease in the target dose. Again, this is just a slide showing how on day one you have your initial planning CAT scan, and then you get as things go on, you may be able to measure with serial scanning accumulation dose. So areas where dose accumulation is important, it can access the delivered dose versus the planned dose. So what is the dose your tumor is actually getting versus what you plan, and predict the delivered dose, what we'll get, and adapt future doses based on what has been delivered, and certainly look at the cumulative dose to normal tissues, which then can be changed. So here's a study that looked at the dose accumulation in outcome studies, and it was looking at obviously prostate area, looking at the cumulative dose to the bladder, and basically found that the total accumulated dose using adaptive therapy was more predictive in urinary symptoms than what you would do initially at the time of simulation. So again, these were patients that are treated normally, but looking at the cumulative dose to the bladder via the changes that you would see on serial imaging, and found that that was more predictive of urinary symptoms than the actual plan you did up front. So here are just some studies, again, mostly physics studies, robust optimization strategies for contour uncertainties. It's even hard to read it for me. Diffuse RT predicting likely anatomical deformations. Again, you have to know what deformations mean. It's in a lot of the literature here, undergoing radiotherapy. You can use this in proton therapy. So again, a lot of work. It's keeping a lot of physicists and PhD physicists really excited and busy in looking at this. So summary, offline is less resource intensive than online. Offline RT is shown to be beneficial in the treatment of some specific diseases, decreased toxicity, increased survival, and local control is the goal. Key elements in offline are imaging and triggers for adaptation. So why do we adapt versus what do we pick? Anatomic adaptation, changing anatomy and normal tissues are sites you really want to look at. Biological adaptation, adapt to response, as I showed you with the PET scan, may be easier to coordinate than offline to save a patient extra trip and extra time. And obviously margin reduction will reduce in more conformal doses to the tumor, and less doses to normal tissue. So I think it's an exciting field. I do believe it's here to stay. It's certainly here with the TOMO units and the MR, and I think it's only going to grow, as we've been saying about all the technology today. Thank you.